An older child presents for follow-up skeletal imaging. I am showing you the radiograph of the hand. Describe the findings.
Um, let's see. Yes. The hand radiograph demonstrates generalized diffuse osteosclerosis affecting all visualized bones, including the carpals, metacarpals, and phalanges. There is a prominent bone-within-bone appearance, where a smaller, denser replica of each tubular bone is visible within the outer cortex. The normal differentiation between the medullary cavity and the cortex is lost, making all bones appear uniformly hyperdense. These features are highly characteristic of osteopetrosis.
What is the differential diagnosis for a bone-within-bone appearance on skeletal radiographs, and how can we distinguish between the causes?
The differential diagnosis for a bone-within-bone appearance can be remembered by the mnemonic Sharp's pool. This includes sickle cell disease, hypervitaminosis D, acromegaly, rickets, Paget's disease, scurvy, post-radiation or heavy metal poisoning, osteopetrosis, oxalosis, osteomyelitis, and leukemia. We can differentiate osteopetrosis by its generalized, dense osteosclerosis. Sickle cell disease presents with H-shaped vertebrae, avascular necrosis, and splenic atrophy. Rickets is characterized by splaying and fraying of the metaphyses, whereas Paget's disease displays cortical thickening and coarsened trabeculation in elderly patients.
Discuss the underlying pathophysiology of osteopetrosis and explain what skeletal complications these patients are prone to.
Osteopetrosis is a rare genetic disorder characterized by dysfunction of osteoclasts, which fail to resorb bone during normal remodeling. As a result, osteoblastic bone formation continues unopposed, leading to extremely dense but structurally fragile bone. Because the bone lacks normal elasticity and trabecular architecture, patients are highly prone to pathological fractures, which often heal slowly. The progressive narrowing and obliteration of the medullary cavity also leads to bone marrow failure, resulting in severe anemia, thrombocytopenia, and extramedullary hematopoiesis.
What are the other characteristic radiological signs of osteopetrosis that we should look for in other skeletal regions?
In the spine, osteopetrosis classically causes dense bands of sclerosis at the superior and inferior end plates of the vertebral bodies, producing sandwich vertebrae. In the long bones, particularly the distal femur and proximal tibia, there is a failure of metaphyseal modeling, resulting in a widened Erlenmeyer flask deformity. Cranial vault sclerosis can lead to narrowing of the skull base foramina, causing cranial nerve compression and secondary blindness or deafness. In the jaw, diffuse osteosclerosis is frequently associated with impacted or supernumerary teeth and a high risk of osteomyelitis.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing these radiographs with prior examinations to evaluate for any occult or healing fractures. I would suggest obtaining a complete skeletal survey, including radiographs of the spine, knees, and skull, to assess the extent of osteopetrosis and rule out cranial foraminal narrowing. I would recommend a brain and spine MRI to evaluate the patency of the internal auditory and optic canals and assess the degree of bone marrow space obliteration. Finally, I would document the findings, communicate them to the pediatric hematology and genetics teams to coordinate genetic testing, and refer the patient for bone marrow transplantation, which is the definitive treatment.